We're going to see the evaluation of hypercalcemia. So first we need to confirm the hypercalcemia. We will do this by either measuring free calcium or measuring or correcting with the formula for calcium and albumin. So we will need to know the albumin concentration. Next, we need to measure the PTH. If the PTH is low, this is, let's say, hypercalcemia independent of PTH. And if it is high, it is dependent on PTH. Now, if the PTH is elevated, why could we have a PTH elevated? Due to primary hyperparathyroidism or a tertiary hyperparathyroidism, because in the tertiary hyperparathyroidism we have elevated PTH, let's say in patients with chronic kidney disease, they develop secondary hyperparathyroidism, and if the glands now become autonomous, they now begin to secrete the PTH, and it's not reversed with calcium, etc. So I think that in the tertiary hyperparathyroidism, I think it as a primary hyperthyroidism imposed in a secondary hyperparathyroidism. Hyperparathyroidism, I don't know if in a part I said thyroidism, but it's parathyroidism. Or that, or in familiar hypercalcemia, hypocalciuria. In this disease, the patient has a defect in the receptors that sense the calcium levels in the parathyroid glands. So they falsely sense as if they were low. So there is a lot of release of PTH, and so the calcium is elevated. There are required higher levels of calcium in order to suppress the PTH. So actually he is elevated or normal PTH. Would be familiar hypercalcemia, hypocalciuria, and lithium. These are our differential diagnosis if we have hypercalcemia and elevated or normal PTH. Primary or tertiary hyperparathyroidism, familiar hypercalciuria, familiar hypercalcemia, hypocalciuria, or lithium. Now, if we have a decrease in PTH, then the hypercalcemia is independent of PTH. This could be related to malignancy, in which case the reason for increased calcium, among other things, would be the parathyroid hormone-related peptide, or, for example, if it is myeloma multiple, that is direct resorption of bone, etc. So malignancy, vitamin D toxicity, so we would have increased reabsorption of calcium and the decreased PTH. Granulomatous diseases, because the granulomatous diseases have the macrophages have the 1-alpha hydroxylase enzyme, that is the enzyme that activates the vitamin D, and so we would have many or a lot of vitamin D, and so hypercalcemia, and then low PTH. Granulomatous diseases, thiazide diuretics, because they increase the calcium levels. Remember that the mechanism of thiazide is, here we have the lumen of the tubule. This is a cell, this is the blood. So here we are restoring chloride and sodium. Here we have a pump of calcium and sodium, and we are also having here some channels of sodium, etc. The pump of natrium and of sodium and potassium, etc. And some channels for which these are going. Alright, so the normal thing is that we reabsorb this natrium here, from here to here, and when we take out this sodium, it usually goes with with chloride, not in the same transporter, but usually. Now this pump is with calcium and sodium. Usually is not working because this puts sodium inside the cell and calcium outside the cell. When does this happen? If we block here this reabsorption of chloride and sodium, then there will be no sodium in the cell, and so this cell is going to take sodium from the blood, and this is through the pump of calcium and sodium. So sodium goes into the cell and calcium goes out of the cell to the blood. And so this is the mechanism why thiazide produce hypercalcemia. Other diseases or other conditions that produce hypercalcemia would be milky alkali syndrome. Alright, now usually for malignancy the calcium level is very high, it's above 14 milligrams per deciliter, and for the other diseases it's usually less than 12, and hypercalcemia is greater than 10 milligrams per deciliter. Now, so here, because these are our causes, what we need to measure here is 25 hydroxycholecalciferol, because it's the most stable form of vitamin D and the more abundant form of vitamin D. But also we will measure 125 hydroxycholecalciferol and parathyroid hormone related peptides. So we need to measure this, and based on this we will try to determine the cause. So evaluation for hypercalcemia, we begin with correcting with the formula for albumin or measuring free calcium. Next, measure PTH. If the PTH is elevated, that is primary or tertiary hyperparathyroidism or familiar hypercalcemic hypocalciuria or leaking. If the PTH is low, then we need to measure 125 the hydroxycholecalciferol or calciferol, 25 hydroxycholecalciferol, and parathyroid hormone related peptides, because the causes would be malignancy, granulomatous diseases, thiazide, diuretics, milky alkali syndrome, vitamin D toxicity, and also immobilization. Immobilization can lead to hypercalcemia.